everyone. My name is Marielle. Thank you all for being here today. As a friendly reminder, for this presentation is CME approved. If you would like to receive CME credits for this presentation, please do so through the link I will put in the chat. We have our Global Offsite Medical Director here, Dr. Pekia, who will be introducing our presenter, Dr. Anita Nelson.
Thank you, Marielle, and welcome everyone to our first session of global grand rounds of the Global Offsite Care Group's monthly sessions. I'd like to remind you that these are CME certified hours, so feel free to complete the forms on the website and your invitation to obtain that fully funded CME hosted by Global Offsite Care. Additionally, you can take up to a week to view the recorded version of this session for those CME hours. With that, I'd like to welcome back Dr. Anita Nelson. So honored to be here with her again today. Thank you so much, Dr. Nelson, for returning to speak with us regarding important topics in women's health, and today on contraceptive options from a global perspective. A little bit about Dr. Nelson. She is Emeritus Professor of Obstetrics and Gynecology at the David Geffen School of Medicine at UCLA, and continues in her role as Professor and Chair of OB/GYN at Western University of Health Sciences. And for over 30 years, she's been Medical Director of the Research Division of Essential Access Health, developing and testing new contraceptive options. She's authored over 200 articles for professional journals, dozens of chapters, and several books. She particularly loves teaching and has delivered over 3,000 lectures for continuing medical education around the world. She's received numerous awards for her quality of care, her teaching, her leadership, and her advocacy for women's reproductive rights. So again, I'd like to welcome Dr. Anita Nelson. Looking forward to your session today.
Thank you so very much, and I'm looking forward to speaking with all of you. I know it's at the end of probably a very busy day that you have. I notice some of you are still joining in. Please feel free to interact. We look like we're going to be kind of a cozy little group. And if there's something that you have as a question along the way, go on to the audio or put it into the chat. And I'll be happy to take the questions at the time if you want to, or we can do it at the end. But this is an intimate little group that we have today, and I think we can take advantage of that. All right, so I do have potential conflicts of interest. I've been involved in research for contraception for decades and have seen the highs and the lows, both for male and for female contraception. And we're kind of in a little bit of a lull right now, but certainly one of the big things that we are researching is what motivates couples to use different forms of contraception or to be committed to them, or how do they plan for their pregnancy, or how do they view pregnancy. And as you might imagine, working with people all the time, that this is really quite a fascinating topic all by itself. But today we're going to talk more about the technology and the method side, but we can't evade talking about the people we're working with too. So we want to just first off take a quick look at the status of family planning globally. We want to look at some of the newer developments in reversible contraception and think among ourselves what practices we can invoke to help people be more successful with their contraceptive use, and by that also with their family planning, yes, so that they get better obstetrical outcomes, and really try to help understand the barriers that remain to reducing unintended pregnancy. And this came out just last year. The worldwide, right now, 44% of all pregnancies are unintended. And you might say, what's the big deal? But of course, you know, unintended pregnancies are associated with substantially increased obstetrical risks and poor outcomes, even if the pregnancy is continued. then we run into far less sanguine results altogether. We have seen a decline in unintended pregnancies over the last several decades, but because there are so many more reproductive aged women, the number of unintended pregnancies has increased. But I just want to spend half a second here. If I say unintended pregnancy rate is 44%, does that mean that all the rest of them, the 56%, are planned and prepared for? And from your own experience, I know you know that that just isn't true. So what is an intended pregnancy? Well, an intended pregnancy is very poorly defined. It is one that is not unintended. So we really need to focus. What are they talking about when they make these classifications? And the unintended pregnancy is very, very specifically defined. At the time that she conceived, she did not want to become pregnant. Pretty impressive, right? Either it was the wrong time or she never wanted to be pregnant again in her life. All the other pregnancies, and I know you see them, right? Some of them are planned for, gee, I want to get pregnant. Some are planned and prepared for, oh, my glucose is in good control. I'm ready to get pregnant now. But huge numbers of them are really, well, if it happens, it happens, right? That's sort of indifferent or ambivalent. I'd like to know if I could get pregnant, but that kind of stuff that leaves her unprepared for the pregnancy. She may not be opposed to it, but she wasn't prepared for it. And it may not come at a good time in her life. So the huge numbers of ambivalent, indifferent, and definitely unintended pregnancies leaves us so far from our goal of healthy pregnancies. Now, you may remember the international standards that we had when we were trying to achieve the global health goals for 2010, that one of the big successes in that story was the decline in maternal mortality. And most of the world, particularly the developing world, huge improvements, big declines in maternal deaths. And a large portion of that was the increased use of contraception. So I think it's very important for us to make sure, using whatever tools we have available to us, including education and counseling, to let women know and enable families to be more successful, having the healthy children that they seek to have. But if we look at it from a global standpoint, it's over 250 million women who want to avoid pregnancy are not using safe and modern methods. And this was a world view, but in this report, 47% countries in there, 40% of sexually active women who did not desire pregnancy did not use any method at all. And I think we have to respect the role that traditional methods can play in helping control fertility. And so we just went through the unintended pregnancy. Let's look at some other aspects of this. And I thought this was a really wonderful title, Seeing the Unseen, the Case for Action in the Neglected Crisis of Unintended Pregnancy. An amazing title altogether. And the 64 countries included in that report, they were able to define that nearly 1/4 of the women were not able to say no to sex. They weren't able to make decisions about their own health care and unable to make any decisions about contraception. And if you add up all of the women that were affected by any of these, so the 8% is not exclusive. It's an additional 8%. And in addition to the 23 and 24, 57% of all women in these 64 countries, reproductive choice is not their choice at all. They have no say in the matter at all. So clearly, it's not just technological things that are keeping the problem persisting. There are clear cultural issues that we need to respect and maybe approach more innovatively to make it happen. This is my child poster for planned pregnancy. This mother had pre-existing diabetes. And whereas this baby looks fairly large and robust and, but it has sacral agenesis and will never be able to walk or control its bladder or bowel function. And clearly related to uncontrolled diabetes. Sugar is a teratogen. We know that women with diabetes have 424-fold increased risk of this very serious congenital anomaly. So pregnancy planning and preparation is very important and can make a huge difference in outcome. And just one more little plea, if I can, for contraception, and we can look at it in terms of the fact that over the last 12 years, the world population increased by billion with a B, an enormous increase. And this was an email photo sent to me with the subject, and where did you say the restrooms were? Clearly, the footprint that Homo sapiens have on this planet is very profound. I think it's important to see what it is women say they want from their contraceptives. And I think it's surprising that efficacy is not necessarily at the top of everybody's list. It's listed for the vast majority of women as one of the top three. Safety is a huge issue, and many women do worry significantly about side effects. There's a huge dissonance, and this was from our patient population. This was an underserved, low literacy immigrant population by and large at my hospital. And look to see, for women who said they never wanted another pregnancy, look how many of them were sexually active but using no method at all. Is that amazing? And how many were using less than the most effective methods? People, and again, we have, you know, that there are differences in efficacy. So there's more than just how well does it work. Yes, we're looking at other factors that can impact choices. And in areas where there are poor resources, it may not be that they have the full buffet of choices. But I think we want to pick and choose and educate people so they can do it. Well, as a starting point, I'm sure all of you know the answer to this question. I don't have it on one of those little fancy things here, but if you could shout out, if 100 couples have unprotected intercourse for 12 months, what percent will get pregnant? And I've actually had people tell me it was 20%. Well, that's 1 month. Okay, the real answer, as I'm sure you know, is 85%. That's how we moved from 7 billion to 8 billion in 12 years, is we're an incredibly fertile species. And I'd like you to remember that 85%. When we're talking about other methods of birth control that, and particularly the traditional methods that have a lot to offer, right? It may not be a pregnancy rate of less than 1%, but if the choice is between, say, 20% and 85%, I think as a society as a whole, we would benefit if we got people who were using no method of birth control at all to use some method that was consonant with their belief systems and their desires. And that may be a 20% failure rate or 25 or 11, whatever it is. We don't want good, right, to be overwhelmed by excellent, or as they say, making excellent the enemy of good. Remember that the background rate is 85%. And if we look, what do we have today around the world is that we have IUDs and implants, and they can run from 3 years to 12 years in how long they work. Very popular in sub-Saharan Africa, of course, and in other parts of the world, so the 3-month injections. We have 1 month vaginal rings, and I don't know if you know this, but coming to your area soon, hopefully, will be a ring that can be used for up to a whole year, but she uses it cyclically, but she only needs to get 1 of them. So it's really going to help a lot with the distribution systems that you have, the drain on how you bring contraception to couples. Then we have the 1-week patches, daily pills, and then of course the whole bevy of things of barrier and, very importantly, behavioral methods. And we have emergency contraception, which I understand is beginning to become more popular in your area. But we have major concerns, things that keep them from being embraced. IUDs and implants require clinical services to place and to remove them. And that also means that we have to have all the supplies lined up. We have to have the training in place. And because women are turning over control of their fertility, right? Because they can't have the children they want by simply discontinuing use of the condom or stopping their pills. They have to trust us. They have to trust us to respond when they request removals. And then the issue about, is it uncomfortable? Is there any pain associated with it? And in our area, we've noticed a fair amount of issues associated with coercion being raised. Whether it's actual coercion or perceived coercion, it is still very deleterious. Injections do definitely affect bleeding. Bleeding becomes unpredictable. And I know that in various countries in sub-Saharan Africa, they've surveyed, and many of the women are very happy to have amenorrhea, but there are groups that are very troubled by the lack of monthly menses, that they have not been reassured or have not accepted evidence that how very healthy it is for them. And so that does make it difficult to make this available to large. And up until now, injections have required supply lines that are intact in several different dimensions. And the fact that if a woman has a problem, this is not rapidly reversible. The combined hormonal methods that have estrogen clearly are associated with an increased risk of venous thromboembolism, which is really the big health risk that we worry most about. But definitely getting supplies to people so that they have them at the time they need them. And then access to barriers and behaviorals, and how are they utilized? We know when we have population studies of how well methods work, typical use failure rates for each of the methods of birth control. And this is what I encourage people to use when they're counseling women about what methods, or families about what methods they might want to think about, compared to what the method has to offer if it were used correctly and consistently. We can see for the implants and the IUDs, they're really right on top of each other, right? That what the method promises is what it delivers by and large. Very little gap there. But if you look at things that are used at the time of coitus, right? Very, very familiar is withdrawal, coitus interruptus, a marvelously effective method. If used correctly and consistently, the failure rate is probably less than 4%. But in typical use, 1 in 5 couples will get pregnant during a year's worth of use. The male condom, which we've promoted for so many different reasons, right? STD, transmission control, all of that could be incredibly important. And if you add a spermicide to that, a safe spermicide, we'll have to talk about that, it could offer things that were in the very top tier of contraceptive efficacy. And these are things people, including men, can do for themselves. They don't need our intervention. But in typical use, we see them with a 13% failure rate. So we have this disparity. And if a couple were to choose to use male condoms, and in my clinic, that was the second most popular method. And I had all of these methods totally for free on hand for today if you wanted it. But male condoms were selected. It's the second most common method. And if that is their choice, then what can we do to help them close that gap between that 13% and the 2%? And I will tell you, I review a fair number of letters of manuscripts from areas around the world, developing countries. And there's where they have data, they are using it very magnificently to look at ways to influence social policy. But the thing I find is that they're really focusing on, well, how do we move people from using birth control pills to using something that works better, like an implant or an IUD? And so they'll do surveys, they'll try to figure out what the factors are that are associated with the use of the most effective methods. When in point of fact, for many of those countries, the real real incentive ought to be to find something that couples will use. They don't have to use the very most effective methods. Again, because at the bottom of this slide is that little memory that if you don't do anything, 85% of the women are going to get pregnant. Okay, so from a public policy, enabling couples to use any method would reduce unintended pregnancy rates the most in most of the developing countries. And even in the United States, the 9% of couples that use no method contribute disproportionately to unintended pregnancies. So even though I'm going to go through a lot of what we call the modern methods, I do want us all as a profession to really consider those traditional methods, the withdrawal, fertility awareness, breastfeeding, and see what we can do to help the people who use those methods make them work better. Well, rather than showing you those numbers, just remember the tiers of efficacy. We have the longer term methods, the IUDs, the implants, and interestingly enough, from a global perspective, the number one contraceptive method is permanent contraception, either tubal surgery. And today, if a woman wants permanent contraception, we've moved to encouraging her to have salpingectomy, because that will also reduce her risk of getting ovarian cancer later in life. But vasectomy, it makes a big contribution. But if you were to look at these reversible methods, most of the people I work with think that birth control pills are the number one reversible method. But maybe you know better. Worldwide, it's IUDs are the most frequently used. Very short, about 26% of couples rely on that. It's 24% of couples use oral contraceptives. So it's head and head, but really IUDs in particularly the contribution that China makes, where 51% of women are using IUDs, that tips the balance greatly. But we've seen the spread and adoption of the use of IUDs in many countries and the wonderful impact that it has. And you have seen the introduction of implants and what a great social impact that can have, as long as we help the women. Then we have your most common reversible method, which is the injectable. We have DMPA, you have NEDA, and then we have the barriers and behavioral methods, and fair amount of new innovation among some of those barriers, and a huge vault forward when you're using fertility awareness, pairing fertility awareness with the cell phone and algorithms that can be downloaded from this has made some of the users, some of the programs that we have actually vie for a position in the top tier of efficacy. When we're talking to patients, we want to remember non-contraceptive health benefits, and certainly the hormonal IUDs have been absolutely amazing at helping us treat. It's the most effective medical therapy for heavy menstrual bleeding and all of the anemias and the health problems that fall behind that. Dysmenorrhea, it reduces the risk of endometrial cancer. It's actually the most effective treatment, medical treatment for endometrial hyperplasia. We can see injections are very important as they decrease menstrual blood loss, dysmenorrhea, and as I'll show you the evidence if you haven't already seen it, the very powerful impact that it has on reducing sickle cell crises. We see many, many health benefits of combined hormonal contraceptives. They've been well studied over the last 60 years. And as we come up with safer estrogens to use in the birth control pill, I think we may see renewed interest in this. And then the STI protection offered by the barriers. So I think the most important references, we tend to use the US medical eligibility criteria, but around the World Health Organization eligibility criteria. There's a quick reference guide from the USAID. There's that eligibility wheel that came out. And then I think importantly, are just as important as who can use what method from a medical standpoint is how do you offer it? We want to streamline the evaluations that need to be done. We want to initiate on the same day. We want to manage the side effects, and all of those things are downloadable for free in apps that you can access. And if you have any difficulty getting the WHO elements, you can certainly turn to the US medical eligibility. And this is the form where each of the methods is evaluated on a scale of 1 to 4 for the different medical problems. So for instance, if she's had a deep venous thrombosis acutely, then you can't give her anything that has estrogen. It's a red category 4. You'd worry a little bit about giving hormonal, but you could give a copper IUD because it doesn't have any hormones. So this is a wonderful summary slide, but it's also embedded in the apps that you have. You can use the wheel where you line up the method of the problem that she has, sepsis, and it'll, for each of those methods, give you on a 1 to 4. So I know you folks have used some of these before, but hang tight. They're just so useful and a great way to teach others, community health workers, many of the others, the pharmacists, whoever is helping couples decide on different options that they have. All right, so we have the US medical eligibility criteria downloadable from the App Store, from the CDC if you want to, and then also the summary sheets that we have. So wonderful resources that are easily accessible around the world and really have given us harmony in how it is that we elevate. Now, there will be differences. The WHO takes a global impact. You'll see in the US medical eligibility, maybe one line for schistosomiasis. Well, that's because it's not a big issue in the US. It clearly is in other parts of the world. And the WHO goes into much more detail, whereas we spend a lot of time talking about bariatric surgery for obesity. So find the resource that's going to work you and your population. And again, this is what we would use, same sort of things, but more detail for some of the medical problems than the ones that you have. So pick and choose, and it's clearly being updated. Another thing that started was the streamlining of contraceptives. We can start any method, any time in her cycle, if we're relatively confident she's not pregnant. So what else do you need to do other than to assure that she's medically eligible? Well, if you're giving a progestin-only pill, she doesn't need anything else. You don't need to examine her pelvis. You don't need to do a breast exam. You don't need to do a blood pressure. You don't need to weigh her. And it'll kick in 2 days. So she only needs backup for two days. Pretty amazing how this has been simplified and standardized around the world. So these are really quite, and simply, again, the implant, you don't have to do anything else if she qualified. It doesn't start working for 7 days if she's more than 5 days since the beginning of her period. But it gives us the flexibility to offer contraception at different times in the cycle. Well, these are some of the things in the last bit that I want to cover for us. These are highlights of the points, and you're welcome to come back and look at those. But I do want to go through each of the methods rather quickly. The contraceptive implants that you're more common with are Norplant 2, also called Jadel or Sino 2. These are 2 implant systems that contain levonorgestrel. They are approved for 5-year use. Probably would be able to extend to 7, but we need to study this. Extremely cost effective in many countries. But the equipment and the training, even this is a very simple office-based procedure for the removal and the placement of them. And you do need a support network for difficult removals. But even so, in resource challenged areas, these simple supplies and training may be challenging. For the patient, she needs to understand the bleeding patterns and the unpredictability. And we need to give her tools to cope with those if they're not satisfactory to her. We have in the US, and I know that in many countries around the world, they have been introducing the single implant. It has a different progestin in it. It doesn't quite have the androgenicity. It's approved for 3 years. ACOG has said for sure it can go for 4 years. And for women who have a BMI less than 30, go for 5. Very, very important to us. When you get down to 1 implant, it's easier to place, easier to remove. And so this is a marvelous standpoint. I'll have to tell you, we're doing clinical trials now for the FDA to get the labeling changed, to see if we can make it on label be 3 or 4 years, or if it depends on BMI. This is very rapid return to fertility. The issue here for many countries is mechanism of action, that if it prevents fertilization, it may be acceptable. But if it were to work after fertilization, but before implantation, that may not be acceptable. So this was designed by the Population Council to guarantee that it would work as a contraceptive, that it would, for at least 2 years when it was first being designed, come out with a method. Now, we know that progestin thickens the cervical mucus so the sperm can't get in, but many people have no idea what a cervix is or what a cervical mucus is, but they do know that if you block ovulation, fertilization cannot take place. So this method provides that very firm wall of cervical mucus for contraceptive efficacy, but also, if you will, for PR, for understanding, for acceptability. It also guarantees no ovulation for at least 2.5 years. So I think this makes things in times when there are value issues that are raised. I think it's important for us to have something to fall back on that we can all agree on the mechanism and feel comfortable offering. We know efficacy is not diminished by obesity, even though the clinical trials did not include women with a BMI greater than 30. We have now 20 years of experience for the first 4 years now, no problem at all. We can certainly place this before the mom goes home after she's delivered the baby, even if she's planning to breastfeed. Really very important. And it's been found to reverse endometrial hyperplasia with atypia. So it has other health benefits outside of it. And here we looked at serum levels, even in BMIs greater than 30, and they were all above the effective level. But it's very interesting. This method has given us insights in heterogeneity among women. We know that obesity plays a role, but are there differences woman to woman or different groups in how they metabolize or absorb hormones? And this seems funny that 60 some years after we got the pill, we're just getting insights now. But this very simple implant, where it's supposed to have steady state hormones for a long period of time, so you wouldn't expect any differences in serum levels from one woman to another, showed greater than a 10-fold variability in the levels that were women. And this may help us understand why it is some women have different side effects than other women do, given the same pill or given the same hormone. And we all have to hang tight with this. They're busy studying what are those differences. Can we identify which women might do better with different sorts of hormones? The implant, I think you probably have also been trained. We're going to stay way away from the sulcus. We put it over the muscle, and the safest muscle to put these over is the triceps. We have effective therapies that help women stop any bleeding that they don't like. And my favorite is to start with high dose NSAIDs, right? I'll give ibuprofen, 800 milligrams 3 times a day for up to 5 days. And that's something she can go home with, so she doesn't have to come back if she gets heavy bleeding. And then we can turn to other things. My favorite there, if you had it available, would be the vaginal ring, because again, you get steady state with it. You don't have the ups and downs. But many people turn to birth control pills and have the women take it for a month or 2 until their bodies and the uterine walls get stabilized. I wanted to share this little tiny trick with you. I don't know if you're doing any removals, but rather than marking the arm with sterile surgical markers, which you may or may not have, and she may or may not appreciate the mark on her arm, but when you use betadine to cleanse the skin before you do the removal, swab the skin and then take a sterile Q-tip with a wooden handle and just place it near the upper end of her arm where you've sterilized, and just strip down And can you see where I've done that? It takes the betadine off the skin overlying the implant. So you know exactly where that implant is the whole time that you're doing the procedure. So it's very easy to do visualization, and it simplifies the removal of the palpable implants. Well, we've already talked about IUDs being the most commonly used method of reversible contraception, and among them, the copper IUD is the most common. And the higher the dose of the copper, the more effective it is and the longer it is. In the US, we use a 380, and we give it, it's on label for 10, many places it's routinely 12. And there are data actually that one IUD placed in a woman in her late 20s can actually last for 20 years. Very interesting. The downside for the copper IUD is the increase in the menstrual blood loss. That's reversible with NSAIDs every month. She can get back down to her baseline, but that does make it a little bit more complicated. We have the higher dose hormonal IUD that has so many non-contraceptive benefits, but it also is incredibly effective as a contraceptive. It thickens the cervical mucus so the sperm cannot penetrate. But as I mentioned, it has all of these other issues on label and off label. And in 108 countries around the world, it's actually used as the source of progestin for hormone therapy for postmenopausal symptoms. So this is the T380A that is approved for up to 10 years. But multiple copper IUDs are around the world. And as I said, the most effective ones have the higher content of copper. But these are the challenges that you have. It's very straightforward procedure, but you do need equipment and you do need training. And if there are complications like perforation, then you have to have access to surgical procedures, and you need to have imaging procedures. And the copper IUD is the easiest to image because it is X-ray, very X-ray sensitive. And the hormonal ones now have barium sulfate, so they should be identifiable, their position. So you might not need to have extensive, but at least X-rays there. We want to place the copper IUD the same day. We can place it anytime post-abortal within 10 minutes of delivery of the placenta. And I think what's really interesting is that in Japigo, trained midwives in Africa, they have actually reported the lowest expulsion rates for postpartum placement of IUDs, better than anything else we've seen around the country, around the world. We quote up to a 20% expulsion rate, and the work that's coming out of your areas there are showing a 5, 6, 7% expulsion rate. So we need to take lessons from what you're doing. Some other tips, and I want to include this here because I know you're going to run into vasovagal reactions with many procedures that you do in GYN. And this article here at the bottom, I strongly recommend if you can get a hold of it. As she begins to feel a little bit funny while she is getting an IUD placed, if you have her not cross her legs, but because she's in the lithotomy position, but bring her legs up to her body and tighten all the muscles in her extremities, you will reverse that pooling and you can abort the vasovagal reaction. So think of all the times when you've had problems with patients passing out, getting blood draws. If you can teach them how to do this constriction, the real art comes when you try to undo that, when you get them to relax. You have to do that very slowly because they'll go over to it. The levonorgestrel releasing, we've talked about that. And here's an actual picture where the sperm cannot penetrate. At the time of ovulation, they can't get more than 2 to 3 millimeters through that cervical mucus. It is the wall of China, and it works very effectively. And it is, we talked about several times, many applications for it. And this is one of the studies that we did that got the labeling to show very, very rapidly the reduction in median menstrual blood loss. By 1 month, women were normalizing. But you know, as we talked about, there are varying attitudes towards amenorrhea. Some women celebrate it, but we have to be aware of the fact that many women might not be happy with it. And that's actually the impetus behind the lower dose hormonal IUDs because they're associated with less amenorrhea. They're smaller size, easier to place, and also lower doses. Well, let's talk for a minute about injectable contraception. We have the intramuscular Depo-Provera, and we also have a sub-Q. And I mentioned this, I don't know how far it's spread internationally, but the sub-Q gives you an extra week every injection on label for how long it works. And very importantly, it can be self-administered. So pretty interesting, since there's a big issue about how you get these injections delivered to women in remote areas on time. Clearly the NEDA, the norethistron enanthate, 200 milligrams every 2 months. And then there are different versions of norethindrone injectables given every 2 to 3 months. And there are combined estrogen progestin injections that can be done in a monthly basis and give women cyclic bleeding. Those are very much more popular in Central America and Latin America. And at the NIH, we are looking to test new compounds that have longer actions so that the reinjection may be every 6 months rather than every 3 months. And that'll be a huge issue for supply issues that you have. Clearly, we can give DMPA and any progestin immediately postpartum, even to breastfeeding women. But for the heavier set women, unless you have a spinal needle, you shouldn't be injecting it gluteal in the gluteus because you're not getting an intramuscular. Giving it in the deltoid is better. And we always admonish our nurses not to massage the site because you'll flatten the thing you've just injected, and it will have a larger surface area and not last as long. I did want to mention a very important issue here, and that is rather from an international standpoint, finally, we have an excellent study that demonstrates that even though the Depo will thin the mucosa of the vagina and the cervix, it is not associated with an increased risk of HIV transmission. Now, it doesn't mean that they shouldn't use condoms, but it isn't putting you at additional risk the way we found naloxone 9 did. So I did want to just streamline these things. We certainly can make this a very quick start. And there's a grace period. If she comes back at 15 weeks and doesn't have any signs or symptoms of pregnancy, she can be considered on time for reinjection. I did want to highlight here the studies that show significant reduction in acute sickle cell crises among women who'd had them before and were known to have sickle cell anemia. And even of the women who did have, the 30% who did have crises, there was a significant reduction in the pain associated with those crises. So I think more investigation, or at least more popularization of this information, needs to be made in at-risk populations. Okay, and certainly supply chain issues are important, and that's where new products like the Cyana Press, where the needle, basically the syringe, and the device all come in one. I can imagine if you didn't have syringes, but you had the needles and you had the bottles of the contraceptives, you couldn't give it, right? But the doctors in the clinical trials here, that was the thing that they were impressed the most with, was not that it could be self-injected or anything like that, but when you had it, you had everything you needed to be able to give it. So I think this is important for many areas. I think we're all subject to supply chain issues, but solutions like this, innovations like this, will make it easier to make it be reliable in offering this as a method. Okay, I want to come to the progestin-only pills and to suggest to people that if you haven't got anything else available, or you have to look something up, you're not sure if she's a candidate, you have to do some special testing, don't just give her male condoms for her method of birth control with a 13% failure rate. think about progestin-only pills. They only have one absolute contraindication, and that is current breast cancer. So very easy to use. And we actually this month, a pill is before our FDA advisory committee to go over the counter. So that's really brand new in the US. I know it's more common for you, but feel free to offer this. We have a new progestin-only pill that actually works as well. It's suppressing ovulation, and it's cyclic, so that women have scheduled bleeding. Want to come to birth control pills and remind everybody that it's the best studied medication in history, is rapidly reversible and extensive non-contraceptive benefits. One of the longest term studies shows that there are no long-term significant health risks, and certainly no mortality issues associated with ever use of birth control pills. So and these were based on studies with heavier doses, higher doses. We know that estrogen will increase venous and arterial thromboembolism, and we have to respect and choose the women we use for that reason. But a lot of the side effects that are commonly attributed to the use of combined pills are not played out when you do placebo-controlled studies. Now, I think there may be significant intra-individual differences, don't you? But when you're counseling people about it, you don't need to say, you should be worried about having this as a conflict. And you may wonder, how do you get placebo-controlled studies for birth control pills? And the answer is when they were being used for non-contraceptive benefits. So think about all the ways that we can use combined hormonal contraception to benefit the quality of life for women, not only to treat their current menstrual problems, but many cosmetic issues and many pain issues. And then long-term, this is one of the only things that we have to reduce the risk of endometrial cancer and ovarian cancer. So let's use our contraceptive hormones to benefit the quality of life. We do see higher failure rates in women with higher BMIs, but that may be related more to non-compliance than it is to the obesity. We do know that if you give a full year's worth of supply of medications, of birth control pills or rings or patches, you can actually decrease unintended pregnancies. We have new estrogen formulations that are going to have, I think, make good impacts, but one of those stay tunes for you. We have the patches, the older patches, and we have newer patches, but we need to remember for all women, a BMI greater than 30 is a contraindication, but it does add the convenience of once a week utilization, and that may be attractive to women. We have the once a month vaginal ring, which is very convenient, and lower doses of estrogen, but it's constant, so it gives us the really good cycle control. And we don't have to worry about obesity, and you can use a single ring for a longer period of time, and you can use it back to back, so you can induce amenorrhea. There is this new ring that came out that has 13 cycles of hormones in it, and I think this company was just acquired by an international company, so you may get to see Annovera. It's once a year, anno meaning annual. So she places it in for 3 weeks, takes it out, and then rinses it off and can reuse it. And it doesn't have any issues about thermal protection, so it can be in hot weather and in cold weather. I want to end, if I can, with a little bit more about the male condom. We now call it the external condom, and the female condom is now called the internal condom because it has been approved for anal intercourse also. And I know you have an amazing amount of experience working with promotion of these devices for STI risk reduction, certainly going on for many other issues that we have today. But I wanted to highlight, if I could, the new size issue. I think we have under-respected the need for different sizes in condoms. And in the United States, we basically have 3 sizes. And I want you to think for a second, if you could, what would happen if we only had 3 sizes of shoes? do you think that a lot of people would go barefoot? And I think that's what we've seen. We hear people saying, well, I don't think, or it doesn't fit. And then we have these cute little diagrams with somebody with a condom over his head or over a watermelon. But I want you to think, how does that watermelon feel with all that much pressure on it that a normal size condom fits onto? So we have come to recognize that there are some challenges. 20 to 30% of women in studies, of men in studies cannot be fitted comfortably into any of the sizes of the condoms that we have. So we need to have more sizes available if we're going to be able to offer this effectively to men. And these are the 3 sizes we have in the States, right? And I show this to you because I love the names. Trojan, Her Pleasure. Oh my gosh, that has a little piece of extra plastic at the tip of the condom. And if that could excite women, I would be so happy with all of my anorgasmic women or other issues that a little piece of plastic could deal with it. But this is for marketing issues. But I want you to know about this. Okay, you can access this, and it is available in the UK. And rather than 3 sizes, they offer up to 60 sizes. And they vary. I don't have the smallest one here, but here, I don't know if you can see this. Can you see this compared to this condom? Can you see the differences here? This is how much men differ, even more so. And to be able to give them the tools that they can use comfortably and be effective as condoms is a huge step forward. So My One Condoms is a wonderful site, My One Perfect Fit, and it gives instructions on how to measure, to know what size condom to offer. And if dabble in it a little bit, maybe that could be something that could be introduced more locally. I know they partnered with us in the States. We put it through the FDA. And so we're not sneaking around to get from some other country. But this is really an amazing step forward in condoms. Now, unfortunately, they're only offered in latex. We haven't got them in the polyisoprene yet, but that would enable so many more men to be able to use it. We have many female barriers and fertility awarenesses. We have having had problems with the contraceptive sponge. It's not as available. And as you know, we've been having trouble with naloxone 9 because it is among higher risk women associated with an increased transmission of HIV, either acquisition or transmission. This is a delightful little method, spongy. It's a barrier. It absorbs the ejaculate. So it's very useful. So it's a kind of a little combination of a diaphragm, but it contains, when you add water, it foams up and it has the spermicide that you need. But again, all of the spermicides are under scrutiny. They are available for lower risk women, but women who have multiple acts of intercourse during a daytime or otherwise. We have another product that has come out that actually immobilizes the sperm. And that one is exciting because it also has been shown to reduce the spread of gonorrhea and chlamydia. So this is a really stay tuned update. We may be able to share it with you. The female condom, the internal condom that we have, really very helpful. And I know many tests were done in Africa. The change in the site is the shape is more oval. This inner ring is used to introduce it into the vagina, and it rests on the outside. You still need to direct the penis into the orifice there. And at the end, she needs to twist the top of the condom before she pulls it out so she doesn't spill anything. So really very interesting new developments. The last thing I want to mention here is something called a 2-day method. And this is something you can train like this. You don't have supplies available. It's a method that has the woman touch the outside. So she doesn't even need to go inside and check things, but touch herself first thing in the morning, right? And ask herself, am I dry? And if she's dry today, she asks herself, was I dry yesterday? And if she's dry 2 days in a row, intercourse is allowed. So it's fascinating that something that simple a technology, all the way up to a handheld computer algorithm base, is all in the same method of fertility awareness. But as a backup method, teach your people how to use withdrawal. What do you mean by teach them? Well, does he know? Screen him. Is he able to anticipate ejaculation? And if he is, great, they're a candidate for it. But then they're limited in coital positionings. You can't have female superior positioning if he's going to be able to get out of Dodge in time to utilize this method effectively. So using the things that people have that they can do by themselves, even if they want to use more effective methods, if they're ever caught in a position where they don't have those, you've given them tools to reduce their risk of pregnancy should they be desirous of having coitus. I think the only other thing, I'm just going to show you some pictures, the internal condom. This is a new diaphragm that is being used, very lightweight with spermicide. It's available over the counter in many countries. There's a FemCap, which I like calling the cervical sombrero, but they don't. This is that pH modulator that I talked to you about that is replacing spermicides as a safer alternative. And this is this phase 2 trial that showed a significant reduction in recurrent infections of chlamydia and gonorrhea among those who use the product for 6 months. And we have, as I've been touting for quite some time, many of these behavioral options that people can fall back on if they want to, and the methods that we have. The last thing I want to talk about is emergency contraception. And this is for the US. I don't know if you ever ran into this, but we just had a Hail Mary sort of a change last week. The FDA changed the labeling on this to say that it does not impact on implantation, and it does not work after ovulation. So it is never going to be called a post-fertilization method. Absolutely a step forward. I don't know that you have that issue, but clearly this gets back to that. How does it work, and will people feel comfortable using it? So clearly we want to have this one available as soon as possible. The longer it takes after intercourse to take the pill, the higher the pregnancy rate is. We have another thing, and that's called Ella, and I believe it's been introduced. It's the ulipristal acetate. It works more effectively than the progestin emergency contraceptive that I just talked about, and it certainly works better for heavier set women, and it works all the way up to 5 days rather than those 3 days I showed you. But getting people to know about these, we had little billboards when emergency contraceptive first came out. So you mix a little bit of humor with a health message, and maybe you can catch it on. And of course, the favorite one was the jeans. Everybody loved the use within 3 days of opening. They got it and they understood altogether. So I'm going to leave you with a t-shirt. In California, we don't go around and share our feelings all that much. We wear them on our chests. And if you look at, this is my t-shirt for family planning. And if you look at it from the perspective of the frog and don't ever give up, keep trying. It makes such a big difference. Thank you so much for your time. Any questions?
Well, I have a comment and a question. I'll lead with the first one. And thank you very much, Dr. Nelson, for just an excellent presentation and review, and the practical aspects of the issues around this topic. And during your talk, we've had a few international guests come in from, I can see from the Bahamas, as well as Yanagawa and in Nigeria. And welcome to you who came in, and also please share the opportunity to view the recording of this session with your colleagues. So my question is regarding the pelvic and breast malignancy risk, sort of across the board, and what and what is the best advice to give individual patients as well as populations regarding that, and particularly in the context of the choices available to them, pro and con. So what about pelvic malignancies and breast malignancies and the use of especially hormone-containing contraceptives?
And I'm so glad you asked, because the only thing we know that reduces both the risk of endometrial cancer and ovarian cancer is birth control pills. Okay. And they do tend to increase the risk of cervical cancer if she's exposed to HPV. But long-term, the death rate is not increased. So I think that that's not an issue. The current users of birth control pills face an increased risk of breast cancer that's very similar to the risk that women who are pregnant face. So I think in long-term, again, the data that people get worried about is from the postmenopausal use when we had estrogen and progestins, and we don't see that kind of pattern happening in young women. And the background rate of breast cancer is very low in younger women. So that risk is from a population base, not much. Now, I think a very important study that came out was to look at women who were BRCA1 mutation carriers and at high risk for both breast and ovarian cancer. And for them, the pill was favorable, because even if there were a modest increase in the risk of breast cancer, it was far offset by the protection of ovarian cancer. So, and that was done in a fairly high risk population in Israel. So they were able to get good data because, you know, they had a good sample size to work with. So I think people are very much more worried about that, but contrast it with the alternative, which could be pregnancy, but it is the estrogen. It's not the progestin that we're worried about. And if we look at the WHO and the USMEC, breast cancer risk after 5 years, it's rated using an implant with a hormone in it. It's a category 2. So those are the women who are at high risk for getting recurrent diseases. They've already had one. So I think in many different ways, when you sample this problem, you face this elephant and you feel around it, you get some very reassuring information.
Great, thank you.
Dr. Harness, is that what you tell your patients?
Thank you. Yes, no, Dr. Nelson, your comments are spot on. You're more of an expert of this than I am, and I primarily deal with postmenopausal women. But I did have a question for you. That was probably the most spectacular overview I've ever seen on birth control. So congratulations. But I didn't hear much about costs. And of course, cost of things worldwide is a major issue. Obviously, the least expensive is the withdrawal method, but do you have cost comparison data that might be very relevant for the low-resourced countries around the world?
I wish I did, but honestly, it depends on the deals that are struck. I remember when Merck gave Nexplanon away for free. Sino 2 was $10 in South Africa, right? The copper IUD just went over $1,000 in the US. It's pennies elsewhere. So the comparisons, yes, as with any medication, you have to look at the impact that cost would have. Is it affordable? And that's actually the cost is not only the device itself, but the whole delivery system. You have to have a speculum. You have to have, the tenaculum. You have to have the sound. And then on the other side, what have I got as a backup to take care of? Yes, once it's in place, you can do that. But I read, the setup is where the woman has to come to a hospital, and the hospital is a day away before she can get something. I train nurse practitioners for Alaska, and IUDs are very popular there because of the supply line. Getting to the birth control pills in the middle of a snowstorm is a bit troublesome. But if she ever gets a problem, like she's expelling it, getting her to health care is a problem. So it's a model we share everywhere. And honestly, the implant, I think, is so easy to train for, yes, and so incredibly effective. I know as a gynecologist, we love the womb. The arm is sort of above the waist there, and how are we ever finding our way there? But if you were from a policy standpoint and the price were right, you can see why so many people are turning to that as a representative of really highly effective methods.
Okay, thank you very much. Again, that was a spectacular overview. Thank you.
My pleasure. Thank you.
Yeah, and thank you for the question, Dr. Harness, particularly from your expertise and experience in women's health, particularly in breast cancer services. So welcome. Thank you for attending today. And maybe a final question. We have one coming in from Bahamas, and Mary Graves, who's also one of our beneficiaries of global offsite care for many years. Mary.
Thank you. Thank you. That was fabulous, Dr. Nelson. Thank you so much. I did want to ask one question I can't seem to get answered, and maybe you would answer it for me. In a late term abortion, let's say 8 months, do they deliver the baby still alive, or do they take the life before it's delivered?
Well, that's so very uncommon that the techniques are going to vary on what they do. Most abortions that we consider late term these days are going to be, the 22 weeker, the 23 weeker. If there's some reason for doing it, if it's a fetal indication, the fetus maybe there are procedures to terminate the fetal life before delivery.
But in some cases, it's better for the woman to deliver it first and then take the life.
Well, we don't take the life after delivery. That would be murder.
Oh. Okay, that's what I wanted to know. Thank you.
Okay, no. If there's comfort care, that this is more of a pediatrician's question, but from my understanding of what can happen, if there is a baby, an anencephalic baby, they definitely keep the baby comfortable, warm, right? They are very humanistic about the care, but they don't do any, what's the word for it? Heroic interventions to prolong life. Am I got the wording right there?
Yes. Thank you.
Great. Okay, well, we're a few minutes over, but unless we have any other questions, comments.
I want to do a shout out to my students. I see them there. And it must be part of your class. It's delightful to work with them. Thank you for partnering with them on their researches.
Fantastic. So, all right. Well, with that, again, a reminder that you can apply for CME credits. For those of you who are interested in that, just go to your invitation and click on forms. We also have in the chat the link for that. And again, thank you so much, Dr. Nelson, for an absolutely tremendous presentation and review on this topic, and also for all of the guests who came in today, to attend the live version of this. And again, feel free to forward out to your friends and colleagues the opportunity to view this asynchronously in the recorded form. So with that, I will give it back to Marielle to close.
Thank you all for coming today. I have put my email and Alex's email in the Zoom chat box if you're interested in presenting. And if you have any questions, feel free to reach out. Our next presentation will be on February 8th. And we appreciate your participation and continued interest in Global Grand Rounds. Have a great rest of your day, and we hope to see you again. Bye-bye.